Cool. So, we might as well go ahead and get started because I don't know how many more people will show up. So, welcome. Thank you for being here. My name is Cinnamon Dixon, and I'm a pediatrician and pediatric emergency physician at Children's Hospital. I'm really excited to talk about this topic. It's one of my great passions, both because of my experience in practice, but also because of the huge burden that we face in terms of injury worldwide, and it's an often overlooked topic. So we'll just go ahead and get started. My only disclosure is that I've been a paid consultant for the WHO for some time now in the area of global injury prevention, and have developed or worked with them to develop many of the extensive tools that I'll be discussing, as well as some policy statements and some curricula. So I want to first start with a personal story. This experience happened to me almost a decade ago when I was in Western Africa, in the country of Ghana, working with Columbia Mailman School of Public Health to implement their emergency medicine initiative on the ground. While working there, at the end of kind of a long day, I received a text from one of the nurse practitioner students, actually the only nurse practitioner student, saying deadly in need of help, which is quite concerning. This nurse practitioner student never asked for my help for the most part. He trained me in a lot of the medical conditions. And so I quickly rushed back to the hospital. And as I approached the hospital, for those of you who've been in the care environment, it was the all too familiar sound of loss, wailing, screaming, crying. So now I'm running through the through the hospital. I opened the door to a very small emergency ward, which really was just a small room with 2 beds. And I noticed that there's about 30 people strewn about all over the floor, multiple amputations, 1 dead, and everybody's weeping and sobbing. In the meantime, we start to have a huge kind of mass of people also trying to get in to find out about their loved ones, as information had spread through the community really quickly about this. So it struck me very quickly that how under-resourced we were. It essentially was a nurse practitioner myself and 3 medical assistants with countless victims, or 30 victims. And what came to light was that a truck like this had overturned down a hill, and hence where we had this mass event. A few days later, it really struck me. I was following behind this exact truck. That's my image that I took. And the inscription on the back of the truck really hit home, both for me and what I saw for those families and those individuals who were in the truck who were at significant risk. And then also, I realized within a few minutes of riding in the taxi that I had hired to go to the northern aspect of Ghana, which was 6 hours up the road, that the taxi had no brakes. And so our driver essentially used the emergency brake the whole way. So my objectives for this talk really are to discuss injury and trauma worldwide, obviously describe the burden of injury and trauma, and common mechanisms of unintentional injury, recognizing factors that contribute to injury risk, identifying obstacles and priorities for the prevention of injury, and ultimately to discuss projections and the control of the 2 leading causes of global unintentional injury. So first to start, the definition as per the WHO of injury is a bodily lesion at the organic level resulting in acute exposure to energy, mechanical, thermal, electric, chemical, radiant, in amounts that exceed the threshold of physiologic tolerance. An important concept to understand when we talk about this topic is that injury is not synonymous with accident. So though prior injury terminology often used the term accident, this reference is really no longer in favor. And that's because accidents are considered random and unavoidable events typically, whereas injury, and the vast majority of injuries, are not random, nor are they and they are unavoidable, or they are avoidable. And additionally, lots of research has shown that injuries can be both predicted and prevented. So understanding that concept, we're going to now talk a lot about the global burden of injury. Not surprisingly, it is a major public health problem and one that merits a much higher degree of attention than it currently receives. So when talking about injury, whether adults or to children, we must recognize that effects of globalization on injury. So in many cases, there have been positive effects of globalization, such as decreasing the burden of infectious disease or other causes of ill health, along with improvements in preventative care and health access, and also improved data collection. Simultaneously, though, there have been rapid and often unplanned urbanization, which is occurring in poorly resourced settings, as well as massive increases in motorization worldwide, often in environments that are void of safety measures. So hence the scales have tipped. And now, more than ever, we're seeing the extent of injury as a leading cause of death worldwide. Injury severity is often presented, represented graphically as a pyramid, with the smallest group at the top of the pyramid, that of fatal injuries, being the smallest number. And since data collection is usually best for severe injuries, this is where most of our global injury data comes from. But non-fatal injuries, on the other hand, are frequent, as you can see from the larger portion on the bottom of the pyramid, and often underreported. And so these injuries, which represent a large burden, and often leave families and individuals with disability and kind of broken social structures, they often, we don't have the numbers for. And that's especially in the latter or lower two categories for injuries resulting in primary care facility visits and those that are treated outside of the health system or not at all reported. What we do know, though, is from a mortality standpoint, injury causes 9% of deaths, and approximately 5 million annual deaths. So to put that in perspective to other really well-known, highly funded mechanisms of death, we know that injury accounts for more deaths than HIV, TB, and malaria combined. From a morbidity standpoint, those that don't end up in death and are the bottom aspect of that pyramid, we know that injury represents 12% of the global burden of disease. Obviously, I take care of a lot of kids, so I really want to highlight kids throughout this presentation. One particular report, which was a landmark document that the WHO put out in 2008, is the World Report on Child Injury Prevention. This report really highlighted the burden of child injury for the first time worldwide, and shifted how we look and understand the effects of child injury on a global scale. From the standpoint of child injury in this changing world with globalization, we have long known that injury is a leading cause of death of children in high-income countries. What this report revealed is that in those countries that are less resourced, the low and middle-income countries, it is a leading cause of child death and ill health. And furthermore, it represents 95% of all child injury deaths worldwide. Again, much of the global data available on child injury is related to mortality. We know that 1 million kids die every year from injury, and the vast majority of these, almost threefold, are occurring in low and middle income countries. So injury is typically categorized by intentionality, meaning that injuries are either described as intentional, and those are the 5 leading ones: interpersonal violence, to 2 different kind of populations, self-directed, war, and homicide. And then unintentional, and these are the leading unintentional mechanisms: road traffic injury, drowning, burns, falls, and poisoning. For the purposes of this talk, I'm really going to focus on the unintentional injury, and that is because it is the leading cause of death, injury death worldwide. So from a mortality standpoint, you can see the pie chart, which breaks down the distribution here. You can see that Unintentional injury makes up nearly 3/4 of all mortality due to injury. So that's essentially road traffic injuries all the way around to this other category, which is more of a bucket in the green. And road traffic injury alone accounts for almost 1/4 of all injury deaths, approximately 1.35 million a year. Similar distribution is found for morbidity. Again, 3/4 of injury deaths are from unintentional injury, and then nearly 20 to 50 million people suffer non-fatal injuries each year from unintentional injury. Back to kids, the distribution for kids is actually quite different. This chart, which is again from the Global Burden document, represents those 1 million children who die each year from injury. And as depicted, 90% of these injury deaths are from are categorized as unintentional. And the 5 major mechanisms, which is road traffic, drowning, fire, falls, and poisoning, represent about 60% of their deaths. So now we're going to discuss factors that are associated with injury risk kind of on a global scale, bringing in some highlights in the US. So oftentimes when we talk about injury understanding and research and prevention, we use the epidemiologic model, which looks at the individual, the environment, and the agent or vector, which causes the injury. I think most of us know that there are specific individual-related factors, such as age and development, or sex, and even race and ethnicity that can contribute to one's injury risk. Similarly, from a social determinants, we can recognize that geography, exposure, socioeconomic or sociopolitical environments, and access to care can affect one's risk of injury. And then finally, from an agent or vector standpoint, we know that there are different behaviors or equipment or specific vessels that can be or cannot be safer, which will contribute to one's risk of injury. So we'll go through these kind of individually. Let's start with age. Age is probably one of the most significant factors that's related to injury rates and specific mechanisms. As you can see here, from ages 5 to essentially 29, injury counts for 7 of the 15 leading causes of death worldwide. Even more concerning is from ages 15 through 44, which is the population where there's typically the most economically productive members of society and are fostering families and communities. We know that this population alone represents over 50% of the injury-related mortality. So an individual in this age group from 15 to 44 getting injured can not only affect the individual, but also affects their family and affects society more greatly. Then, when we look at kids, we know that from ages 1 to 4, the two kind of leading injuries that are represented as drowning, road traffic injuries, and fire-related burns, and across the board, drowning, whether globally or in the US, is the leading killer of this age group in terms of unintentional mechanisms. And that we see within the US statistics. So this is from the CDC, from a US burden standpoint, and you can see from ages 1 to 44, unintentional injury is the leading killer of the population in the US. So let's talk about sex. This is obviously another factor which greatly contributes to one's injury risk across the board. Injury mortality rates, comparing males, which is in the yellow, to females in the green, are nearly double, sometimes triple, that of females. The only exception is that of fire-related burns, where the mortality rates of females and males almost starts to become equal. Now, when we look at race and ethnicity, the global data really focuses more on the socio-environmental factors and the geography, which is sometimes complex when we look at race and ethnicity. Having said that, I want to highlight here, this is US data that shows unintentional death rates are higher in American Indians and Alaskan Natives. They are lower in Asians and Pacific Islanders, and whites and African Americans tend to have the same unintentional mortality or injury rates, with the exception of one mechanism, which is drowning, where African Americans tend to have a 45% higher rate of drowning. Now, kind of shifting gears to the kind of environmental piece of our epidemiologic model, we know that obviously economy plays a huge role in one's risk of injury as well as one's outcomes for factors that we'll describe. We know that based on the gross national income per capita, low and middle income countries have the highest injury rates across the board. And 90% of injury-related deaths are coming from these countries. This graphic just kind of depicts the distribution based on the gross national income from the World Bank and their number of deaths per 100,000 population. From a regional standpoint, and these are using the 6 WHO regional definitions, we know that 2 regions in particular, which is the Southeast Asian region and the Western Pacific region, which are represented from the yellow and the gray, exceed 50% of the global burden of disease for injury, both in terms of mortality and then also morbidity. And then, of course, this is quite complex, right? So much of these economy or these regions are in the low and middle income country economies. And unfortunately, these are often areas where prevention strategies are void and policies are also lacking. We see similar socioeconomic associations here in the United States. So to compare that with us, we know that lower socioeconomic status have higher injury rates. These are households that have lower income, lower maternal age, lower educational attainment, more household occupants, single parents, and multifamily dwelling units or overcrowding all have a higher risk of injury. We also see geography play a role in the United States. So this graph is representing from age 0 to 19, but it's similar across other populations as well, of mortality rates due to injury. And as you can see, the blue, those in California and some of the Northeast, if you were severely injured in those locations, you're probably going to have a better outcome than those in the red, where you're unfortunately going to have a higher rate of mortality if you have severe injury. Of course, one really big piece of this is access to care, right? So, or lack of access to care. We know that globally there are infrastructure shortages. There's a lack of basic trauma care knowledge and services across the board. We also know that there's substantial workforce mismatches. So for approximately the 800 million people living in the African region, who represent about 24% of the global burden of disease of all kinds, they are only served by about 3% of the health workforce. Compare that to the American region, where we represent about 10% of the global burden of disease, yet we are served by 37% of the workforce, and unfortunately, we also count for 50% of the world's health expenditures. So because of these challenges within care, we know that mortality is worse if you are injured in low-income countries. For example, a study out of, that was published in Journal of Trauma by Mock, who's a colleague out of the WHO from years ago, showed that if you have the severe trauma as an adult in a high-income country compared to that in a low-income country, your risk of dying is significantly more. So about 35% of low-income or high-income countries, severe trauma for an adult will die, compared to 63% in a low-income country, and that 6-fold increase is seen even in moderate trauma for adults. So kind of understanding what the burden is, which is massive, right, and the risk factors associated, we're going to kind of shift directions and talk about prevention and projections around 2 major areas. So starting first, though, with obstacles. So some of the biggest challenges that we see in injury prevention have to do first with, backwards, let me just throw them all up here, lack of data. So first and foremost, we know that, that for a lot of countries or a lot of regions, that improvements in collection of data have only just begun, right? And then for many of these settings, this is where their injury burden is the most substantial. And for example, the WHO Injury Chart Book, which was published in 2002, which was really the first global injury document published for the 17 million deaths that were captured per year from vital statistics, that was essentially recognized to be probably about 3/4 less than what is actually out there. And in large part, that was because of countries not having enough data and them needing to extrapolate from other countries in the area. I think this chart up here on the right, or the figure on the right, is really graphically evident of our lack of data comparing injuries to other causes. So this is from the 2017 Lancet article, Global Burden of Disease Study. And as you can see, this is a data density figure. And so for each of those dots, it tells us the data density over time. So it's from 1990 to 2017. And you can see that across the board, injury compared to the other categories, which is non-communicable diseases and communicable diseases with maternal health, and that injury data is lacking, even despite the fact that we've been now almost 3 decades of trying to capture this data. A second obstacle is the knowledge transfer gap. So that's what works, what doesn't work, and what's actually appropriate. So we know that there are prevention strategies that work in our setting. Whether that's appropriate and or even feasible for another setting is always a question. I will give a quick example. About 5-6 years ago, I was giving a talk on global child injury to a bunch of national injury experts, and a question from the audience, which was good, said, "We know what works. Why don't we just bring it to them?" And then that individual is correct in some respects, right? So we know that 4-sided fences work, right, around a pool to prevent drowning. We know that fire alarms and smoke detectors work. But then I always challenge audiences to think, or any of us to think about, how do we prevent injury in a global scale? So how do you put a 4-sided fence around a river that's a community's only access to water? Or how do you install a smoke detector in a community that cooks outside and has no overhead roof? So not all strategies are either going to work or even are feasible or appropriate for every setting. Of course, other obstacles, which we see in a lot of kind of healthcare realms, are related to understanding and commitment, and then lack of kind of a coordinated multi-sector approach. So whether domestically or internationally, gaining stakeholder support for injury is often one of our biggest challenges. Prevention efforts are often lacking. In addition, emergency and long-term care infrastructure, like I discussed earlier, is lacking. And then essentially not having enough of a coordinated approach doesn't allow things to be scalable. So if we kind of flip all those obstacles to priorities, which they are, this was from the WHO Child Injury Report recommendations, but they can be more broadly described, that we should be integrating injury into a comprehensive approach to health, developing and implementing prevention policies and action plans, specific actions to prevent and control injury, which we'll talk about some examples of, strengthening, of course, our health system to give better access to care, enhancing data, which helps us kind of tell policy leaders what the funding priorities should be, of course, defining research and funding priorities, and ultimately making awareness both in the communities and the public health officials and policies to target investments. So from here, I really want to just focus the last section of our time, taking a deeper dive into 2 of the leading causes of unintentional injury death worldwide. As most of you know, road traffic injury, like we put up earlier, is the leading cause of unintentional injury death, whether globally or in the US. This includes, of course, those who are occupants of a vehicle or perhaps even walking alongside the road, pedestrian, but also bicyclists and motor bicyclists, really any road user. So what we know in terms of projections is that over the last couple of decades, unintentional injury has stayed pretty much in the same spot at level 9 in terms of global burden of disease, but it's anticipated as, again, some of these other diseases and causes of ill health shift down, and we have more motorization, that it's quickly going to become 3rd in terms of the global burden of disease by 2030. Having said that, a safe system approach at road traffic injury helps ensure that we are creating an environment for all road users. Some of these are things that most of us are aware of, that safe roads decrease one's risk of injury, and specifically having traffic calming measures like bumps and humps and roundabouts, separation of road users, whether that's pedestrian lanes or bicycle lanes or even motorbike lanes, and safe cross points have all been shown to decrease the risk of road traffic injury. Similarly, safety regulations for our vehicles, impact regulations, stability control, anti-lock brakes, airbags, seatbelts. We also know that lower speeds decrease our risk of injury. For example, for every 1% increase in our mean speed, we have an increased risk of fatal crash by 4%. Of course, no drink driving, right? That's typically how it's said in other settings, not drunk driving, but drink driving, which really just means alcohol, any kind of drugs increases our risk of death. And then we do know that properly fitted and properly placed helmets can reduce the fatal risk of injury, or the risk of fatal injury, by about 42%. Seatbelts can reduce one's risk of death, at least in the front seat, as a driver or a front seat occupant, by 45 to 50%, or in the back seat by 25%. And then, of course, child restraints can show a reduction in about 60% of deaths. So in 2010, with the support of the Bloomberg Philanthropies, as well as in coordination with the UN and ultimately the WHO, the Decade of Action was set in motion. So this was from 2011 through 2020. This initiative sought to save millions of lives of individuals using this safe system approach, looking at all kind of those factors, the safe vehicles, the safe roads, the behaviors, and then safe equipment. And further kind of essentially informing communities and policymakers about steps to how to prioritize these factors. Having said that, in 2015, the UN adopted their first series of road safety SDGs, which is wonderful. It was really a big injury prevention win for the first time, having that get recognized on a global scale, that road safety is essentially a prerequisite to living healthy lives and promoting well-being worldwide. Within the following kind of decades since the road safety report, the WHO, along with collaborators worldwide, have created countless documents on road traffic injury. These are just a few. I'm going to highlight this last one because we'll go a little bit deeper into these. This last one is a global safety report, or global status report on road safety. And this is the second edition. The first edition was published in 2014. And what this specific document really tried to do was stimulate action from each individual country. So if you look at this document, which is freely available, as are all their documents, online, or if you wanted a paper copy, you can always write to them and they will send you one. Essentially, it allowed for all the member states to know where they are on certain UN recommendations and be able to benchmark across the board to other countries on those recommendations. What we know is, of the 175 member states or countries that participated in this report, at least 123 had met some best practices for at least one or more of the risk factors or recommendations. And then additionally, another 22 countries had amended some of their laws or risk factors to bring them in line with best practices. So, having said that, there's still a lot of room of improvement. So what we know, let's just talk about road safety, the specific roads and being safe. Of course, there are certain recommendations of what that looks like, whether it's speed humps or bumps, which is traffic calming measures or separation of road users. And they, in terms of the ranking, which is in this report, depending on which of the road user it is, there are those recommendations. Unfortunately, because there's still quite a bit of room for improvement, we know that 80% or 88% of pedestrian travel, 86% of bicyclist travel, and 67% of motorcyclist travel are still happening on 1 to 2 star roads worldwide. When we look at vehicle crash standards, while there are 40 countries that are implementing almost all of the UN recommendations for safety standards, unfortunately, the vast majority, 124, either have none of those or at least just one of those regulations in place. I highlight these last 2 slides really to show where we in the US still need improvement. So this is our helmet law and where we stand in terms of helmet law compared to the remaining world. As you can see, we're doing a fairly poor job. So red essentially is not covering all riders, or roads, or engines. And that's where we are right now compared to other countries which are less resourced, such as Brazil or India, or even parts of Africa, which are outperforming us in terms of their regulations on helmets. From a child restraint standpoint, we also have room for improvement. You can see that we're doing marginally. So the orange represents children are under 4 are covered, and between 4 and 10 not being sufficiently covered in terms of our regulations. And there are other countries, primarily in Europe, which are outperforming us. So after talking a little bit about road traffic injury, I'm going to switch gears and now talk about drowning, which is the other leading cause of unintentional injury, if you think back to our pie. And really, this is the leading killer of kids and young people, again, globally and in the US. Although the projections are not as clear-cut as road traffic injuries, what is certain is that, as we have seen in the gray, kind of mortality decreased from other causes over the scope of the last almost 3 decades. And yet, the dark blue along the bottom is drowning mortality has stayed fairly consistent. We know that the larger percent of all deaths is being represented by drowning. In 2014, the first landmark report on global drowning was published, which really, again, highlighted that unlike other injury causes, individuals that drown have often a fatal consequence. This is one quote that is pulled directly from the document, which I think is poignant. It says, once someone starts to drown, the outcome is often fatal. Unlike other injuries, survival is determined almost exclusively at the scene of the incident and depends on 2 highly variable factors: how quickly the person is removed from the water and how swiftly proper resuscitation is performed. Thus, prevention is vital. So, within this document, there were 10 specific actions that are recommended that all countries and communities start to implement to prevent drowning. These actions were based on communities as well as policies and legislation, and lastly, further research. These were determined to be evidence-based, both feasible and scalable. For the kind of 5 major intervention ones, that's installing barriers and controlling access to water, not necessarily 4-sided fences, but barriers along houses, especially those homes like in Bangladesh who reside over the water, even having essentially like playpens that are given to communities so that the kids and small children can actually be contained, so that they're not wandering around water, even just dumping over or emptying out buckets and keeping buckets upside down for the rainy season, and covering wells and cisterns. In terms of safe places, the recommendation is to have essentially a safe place with supervision away from water for preschool-age children. So they created creches or little daycares in the communities. There was a shared kind of model of care provision of the kids while others were able to do tasks. Of course, teaching school-age children basic swimming and safety and rescue skills, training bystanders to have appropriate rescue immediately, and then strengthening awareness, highlighting the vulnerability of kids. Following the 2014 report, about 3 years ago, an implementation guide to prevent drowning was put out by the WHO, which really is a pretty unique guide in itself. It takes countries or communities essentially through a step-by-step process of trying to address drowning. Specifically, kind of looking at these 3 domains, situational awareness. So domain 1 really describes how best to create the situational assessment, which is a prerequisite for drowning prevention or any kind of prevention in any setting. And it reveals what is already taking place and efforts to deal with whatever that prevention is, and specific for this, it's drowning, and then also includes a lot of stakeholder and resource analysis. It guides these 6 different interventions thoroughly and ultimately gives some cross-cutting implementation strategies to implement these in each of those settings. So it also highlights several countries and communities that have done this effectively, and I just want to highlight this one because I think it's really great. I mean, there were several that were wonderful, but this one is particularly great in terms of it captured a large population of kids across 3 countries and had great data to kind of follow these kids. So this was the Swim Safe initiative that was out of Bangladesh, Thailand, and Vietnam, which was implemented in 2006 and has since taught over 500,000 kids how to swim, how to rescue, and how to have survival in the water. The exciting thing is that it provided robust evidence that it was effective at teaching kids to swim 25 meters and tread water for 30 seconds. And for those kids that it had effectively taught that it decreases the risk of fatal drowning in their environment. And then furthermore, the follow-up study showed that there was no increased risk of kind of engaging in risky behaviors around water after this. These are just 2 images within the document that kind of highlight the survival skills, which is the top one, which they had to be able to float for 30 seconds. Other skills that were taught was breathing, blowing bubbles, swimming skills, and treading water, and then elementary resuscitation, which this is an example of being able to be rescued by a pole. They had to learn how to be rescued themselves by a pole and also how to rescue others with a pole. So I guess the question is now, where do we go from here, right? So we know that injury is a huge killer worldwide. There's lots of risk factors. And that there's a huge need, but there are interventions which are effective. I would say, at least looking kind of introspectively, I think the first and foremost thing that we need to do is make sure that we are choosing safe behaviors, both here and abroad, and modeling it for our families, our communities. And remembering that, and I didn't cover this, but it is indeed true, there's been several studies that have shown that injuries are, of course, leading cause of death in the United States, but also among travelers. For individuals who are going to high-income countries, you're more likely to die by injury than any of the other infectious diseases, especially road traffic injuries. Getting involved in injury advocacy and education, again, in our own small kind of cohort that lives next to us, our neighborhoods, or more globally. And then finally, recognizing that there are interventions and programs that work, and there are resources that can help us help others. I'm just going to leave you with this image and this quick story. This is a picture from Tom Bishop, a former WHO injury expert in Tanzania. And this picture is of the near daily happenings of kids who are hit by cars. So in this community, when word would get out that there was another fatality, all the kids would gather at the site and essentially stop traffic, stop kind of all other community activities, and chant until someone came out there and started to work on the road that would say tunataka tuka, which means we want to bump, slow down. And we should all really take that passion and drive and force and demand more. So just the highlights. Injury is a huge cause of morbidity and mortality globally. Low and middle income countries are disproportionately burdened. Lots of factors, whether from the individual, environmental, or agent perspective, contribute, and that there are interventions and strategies that work, but it has to be multi-pronged, and it really does require all of us. So that's all I have. Thank you again. I appreciate everybody coming today. I didn't know if anyone would show up. Questions? Yes. Yep. Right, so I'll just repeat that for the sake of the recording. So Dr. Berman asked, because injury often needs community involvement first, how does the WHO go about involving these communities? Because for many of these communities, it's not on their priority list. So I can speak to at least the few initiatives that I'm aware of. And those initiatives really stemmed from collaborations that they had already ongoing with the WHO. Having said that, you are correct, and I echo what you say, in that you have to have community involvement. And whether it's injury or other implementation of interventions, it really needs to be owned by the community and to be essentially scalable and deliverable and sustainable by that community once people come and essentially whether they help implement it or inform about how to implement it. But for the couple that I know of, the one that I mentioned, the Swim Safe, that was an established relation that had already commenced with some individuals with WHO in Bangladesh and just kind of expanded out. But I think it's unique to each situation. I think one of the biggest things that is probably the most important, which I love the fact that the implementation guide brings this into the discussion, is that situational assessment, but including in that situational assessment, how do you gain stakeholder involvement? How do you not only bring awareness and find out what the data shows, but bring people who are able to actually implement this and sustain it longer term to the table? Yeah. Yeah, it's great. Yeah. Mm-hmm. Yeah. Yeah, so Dr. Robin just said essentially that in Asia there's been a big change in terms of helmet use, especially around adults, and that despite that, how the governments kind of go through the implementation and policy kind of build up, as well as manufacturing of enough helmets. That's what I'm hearing you say. So I think it depends on every circumstance, right? Dissemination of the information and data is really key, and I think it requires the countries and policymakers to see both the burden, but the cost, similar to legislator, right, to make policies. And then there's not even just the making of policies, but the enforcement of that. So a policy may exist, but if there's no enforcement or there's nothing in terms of the feasibility or the manufactured number of helmets to actually put on heads, that's a challenge too. I think it really just requires multiple stakeholders at the table that really goes beyond just the individual small communities, which brings in your public health authorities. The WHO pulling in individuals from there can help. Because the truth is even though the WHO has its statements and is able to bring information on best practices to the table, even to the United Nations member states, it has to come from within, both policy setting, enforcement, and regulations around manufacturing. I'll just briefly say that in 2009, I was working in Brazil on an epidemiologic study in one of their trauma centers, and they had just put out the policy that said that kids should all be in car seats, which is a wonderful policy, but they didn't have car seats. And they still don't have car seats, not nearly enough. And for those individuals who can actually afford them, that's a really kind of select and small group of individuals in the population, right? But so they had this policy that wasn't enforceable, nor was it attainable because the manufacturing wasn't there yet. Mm-hmm. Mm-hmm. Visibility. So the question is there evidence that the bright kind of yellow vest, which you'll also see in Asia, actually reduces motorcycle deaths? So there is evidence that visibility decreases the crash risk. I'm not familiar with any study that specifically states the visibility using vests like that, but visibility for sure decreases crash risk, hence why we all have now daytime running lights on our newer cars. And that's been shown. But I'm not certain, I mean, I could look it up if there's actually good kind of robust studies that show those vests make a difference. It would make sense that it would make a difference because, again, it's about visibility, something bright that catches your eye when you're in your blind spot, just like a running daytime light. Right. Yep. Yeah. So I'm just going to repeat that as best as I can for the recording. So Dr. Hayes just essentially said that based on the basic trauma care initiative out of the WHO, and I didn't say that correctly, that there's now more standardized data collection for a lot of these countries, and especially though they're taking ownership in the individual country, there's quite a bit of more of a kind of trauma registry that's trying to be more global in terms of how they capture it worldwide, and that's readily available. So for people who are interested in looking at some of that data that's there, I will also echo that. That is the WIS scars, if people are actually interested in injury or trauma research related in the United States, WIS scars, the CDC WIS scars site is probably your best site. It's WISQARS. And that you can drill down to ICD knowing code of whatever trauma mechanism, even community like Denver and this zip code, fatal deaths, hospitalizations, all of those. But that's wonderful that they're doing that because you're right, they have started some starts over the years. Thank you all for coming. I appreciate it and the great comments.